I've been involved with this EMS education for quite a while. I'm currently the representative representing ROC for Canada and the US, and we're trying to get more people from the field involved because all of this research involves paramedics and firefighters. So they'd realized a few years ago when they asked me to do this that if we're not getting people from the field speaking up, we're not necessarily going to get them involved. So that's how I've become. And as you see, I've been a practicing paramedic for 32 years. I just retired, but I've come back part-time because the way our system works is you retire and collect a pension, but to make the same money, you still got to keep working. So I'm still working. I mean, that's my story.
So we're going to do a three-part presentation. I'm going to do the first part, Ron will do the second, and then Steve will finish up and bring us home. And in between, we're hopefully going to have some hands-on stuff, which will hopefully break up the cycle. If there's questions, please stop us. I will have time for questions at the end as well, hopefully. And we will go through some of these slides fast because we want to save some time for the practical portion of this. So let me give you a ROC overview. ROC was created by the NIH in large part to address some of the issues that were mentioned earlier in this conference, that there is very little resuscitation research been done over the years. We do a lot of things in EMS. And we do them because either someone told us or that it works, or it was a good idea, or we have what we call EBM, but that EBM is not evidence, but eminence-based. It means somebody that is authority says this is how you shall do it. And there's been a lot of interest in sort of asking some basic questions. We've done a lot of things, but maybe we're not doing them right. So ROC was brought together by the NIH as the first pre-hospital consortium to actually do out-of-hospital studies looking at day-to-day stuff we do in EMS to whether it makes a difference or not, and actually look at existing therapies, potentially new therapies, new drugs, devices, even potentially deployment strategies, maybe 4-person companies, 3-person companies, paramedics versus BLS. All those things I think are potentially studyable through the ROC consortium. There are a lot of past practices that we have carried. I learned a lot of these, but have ultimately proven to be not true. A great example was masks. When I first started, everybody carried masks. You had to be so careful when they came into the trauma room that you didn't cut off those pants because they're $1,000 each and someone's going to have to replace them. And Lord knows an intern's salary was not enough to cover those days. Hyperventilation. We used to hypervent everyone until we realized, boy, maybe overventilation is bad. And actually turns out now we purposely try to not hyperventilate unless they have clear signs. And even then it's controlled hyperventilation. Another great example was suppressing PVCs. When I grew up did my medical training, we spent time trying to control PVCs post-operatively so that people wouldn't get arrhythmias, and we used to send people home on drugs. We found out that the very drugs we gave them to prevent PVCs actually increased their risk of having an arrhythmic death. And so a lot of things that are historically based have to be questioned, have to be asked, and you have to actually constantly challenge yourself. And what I do today, is it actually the right thing to do? And how can I make it better? And the old axiom is that 50% of what we do today is wrong. The problem is that many of us don't know. And unless you're willing to ask those questions, we'll never find the answers. And ROC was brought together to actually try to address some of these issues as it applies to EMS. So the ROC site map is up here. You can see there's 10 sort of large communities covering about 25 million people. There's a lot of EMS agencies, about 250 plus agencies with a lot of hospitals and a lot of providers, over 20,000 EMS providers involved in the ROC effort. It is funded as a nonprofit approach, so we're not held to by anything that industry does, so we're not looking at stuff only that industry is interested in, is biased towards. But we're actually funded by the NIH and government organizations like the Canadian Institute of Health Research, as well as the American Heart Association and the Heart Stroke Foundation of Canada. The Defense Department is also interested in what we do because a lot of what we learn from ROC applies clearly to the military setting, and that's why the Department of Defense is also a partner with us as a funding agency. Why is this important to firefighters? Well, if you look at the agencies that are participating in ROC, 185 of the 215 agencies, 214 current agencies, we had more when we first started, are fire departments. That's 86%. So this has really practical implications for all of you that are involved with the fire service. ROC started in July of 2004. The first studies began in December 2005, and the first funding cycle completed in 2010. We're now on a second funding cycle, and the next set of studies are about to start. We're going to sort of summarize what we learned from the first phase of ROC and then talk about some of the directions we're going in the next phase of ROC. The accomplishments to date, we've enrolled over 100,000 patients approximately in the various studies we've done to date. We'll talk about hypertonic saline. We'll talk about something called rock primed as well as epistry. And then we'll talk about some of the challenges of doing this kind of work because we have so many hospitals involved, so many agencies, so many communities that to get through the research ethics boards has been at times a major challenge. A lot of the studies we do in EMS have to be done under certain guidelines that are called exception from informed consent, which in itself is a challenge, but we're not going to touch deeply on that today. Let's first talk about the epidemiological registry. Right now, this registry has over 100,000 case entries that have been done so far, and this is the largest cardiac arrest registry base in the world. Okay? We have that much data in the first 6-7 years of ROC. We collect every single cardiac arrest. We collect every single death on the scene. We also collect very sick trauma patients, those with a blood pressure less than 90, a GCS less than 8, and severe respiratory distress or field intubation. And we're able to actually track these to see what's going on. I'll show you some of the things that we've learned from this. So far, 35 plus papers published, a lot more in the pipeline, and you'll continue to see this, and it'll change the way you practice, I practice, and how we think about resuscitation. I've picked 3 papers that I'm just going to go through very quickly to kind of highlight some of the things you can learn from registry work. Now, when you do registry work, these are observational studies. The downside of an observational study is you cannot control for all biases. Certain things happen in an observational study that you cannot control for, and that's why you also need something called a randomized controlled trial where you try to remove bias, and we'll talk about those in a second as well. So the first one is the regional variation in incidence outcome of cardiac arrest. Second one is the importance of CPR fraction in survival from cardiac arrest. And the third one is the myth of the so-called golden hour, at least as we know it in EMS for trauma. So the first one was published in JAMA 2008 by Dr. Graham Nickel and other investigators. And what we looked at here was use the same data collection method across all these communities and all these agencies and looked at what's the difference in outcome between the 10 different sites that are participating. Now, in this database, not every community contributed cases, so you'll see that there's sometimes it's 7 cities that are, or 7 communities are part of it, sometimes it's 8, sometimes it's 9, but you know, the idea was to compare and look at what the difference was. So you can look at the this is the incidence and outcome of out-of-hospital cardiac arrest in these communities, and you can see that the incidence and outcome varies dramatically. If you look at Alabama, the survival to discharge from all comers of out-of-hospital cardiac arrest was 1.1%. And if you look at Seattle, which is the winner in this comparison, is 8.1%. But you see a huge spectrum all the way from 1.1 to 8. And there's a whole bunch of numbers in between. Why? What's the difference between one community and another? What's Seattle doing that Alabama's not? Or what's Seattle, you know, or what are we doing in Portland? Because we have 6.5, but what can we do to get better to 8.1? This concept of comparative effectiveness research, comparing what one community is doing to another in all areas, is becoming increasingly important in healthcare economics. Because if you're going to invest dollars in healthcare, and EMS and fire services provide healthcare dollars and use healthcare dollars, we need to look at what's going on. And that's why this is important. If you look further at VF, which is the best rhythm you can get survival from, it's just as marked. The survival in Seattle-King County is almost 40% if you have witnessed VF. Yet the survival is as low as 7.7% in some communities. Why? And we need to look at this more, and you'll see some of the things we're going to talk about today that King County is going to talk about as to what they do, and maybe these are the things that we could be doing uniformly to improve survival from cardiac arrest. So there's a wide system variation. What I've just shown you for cardiac arrest also exists for trauma. The outcomes from trauma vary from community to community. Why? What are they doing in one community that's better in another or worse in another community? We need to understand this to try to improve our healthcare system. So later, one of the King County EMS system, which has one of the best survivals from cardiac arrest, will highlight some of the things that they do and to sort of highlight why we might be seeing some of the differences. The second big thing has been this American Heart Association change in guidelines since 2005, 2010, the so-called back to basics. You heard today that 90% of what EMS does is basic life support. And getting back to the basics is something we had I think, at time forgotten. So this paper looked at the importance of compression fraction both just before you give the shock and right after you give the shock, to survival from out-of-hospital ventricular fibrillation. We've always known that it was important, but we didn't understand how important it was. So Dr. Christensen and company looked at this. Now, the chest compression fraction is the amount of time in a minute that you're on the chest. Every time you're off, that's basically no compression or no flow, but it's the amount of time you're on the chest. If you look at the results of this, and we can show you, and you were seeing that today again with Dr. Pepe's presentation, that we are off the chest a lot. Sometimes we do pulses, it's intubation, it's old habits, it's focusing on drugs, getting away from the basics. So you can see when you look at the CPR process files, interruptions are very common. The most common one for me is intubation. But you can see that as your chest compression fraction goes up, your odds of survival go up threefold. So if you want to bring that VF patient back, it's really critical that when you have your team running that code, that chest compression person really stay on that chest as much as they can for that, for that time frame. So the proportion of time spent performing chest compressions before and after that shock has a substantial impact on the survival from cardiac arrest in terms of VF. The last paper I'm going to highlight just from Epistry is one done by one of my colleagues, Dr. Craig Newgard, looking at the intervals in trauma. And this is sort of highlighting the trauma stuff that we're doing, looking at the impact of certain intervals that we've always sort of thought are important when it comes to EMS care for trauma patients. So we have a rule in our system that it's 10 minutes, and you got to be off the scene in 10 minutes on a trauma system entry. Well, where did that 10-minute come from? It was pulled out of the hat, like just decided, right? Eminence-based medicine. Somebody decided 10 minutes is the right number. What's the evidence for 10 minutes? There isn't much. We actually looked at this in ROC. We looked at all the factors that predict outcome in trauma patients. And it turns out that time does not. If you look at the total EMS time, response time, scene time, and then transport time, that has no impact on predicting outcome. What actually matters most are things like the age, transport was important, GCS score and blood pressure, things you'd expect. But time really didn't matter. So if you take an extra 2 minutes to safely extricate someone, that's not going to make a big difference. Yet sometimes, the 10-minute rule got sort of enforced. And these are the things that I think we can help answer through observational work like the ROC Epistry. Okay, so really the take-home point was, at least in this large group when we looked at it, there was no impact from time and on outcome from severe trauma. Let's flip now to, that's observational work. Remember, observational work is very good, but it has biases because things get done depending on how you were trained, and you may be biased in one direction. The ideal way to do a study is to do what's called a randomized control trial. It's also very expensive, so it's hard to do. And as I said, there are rules such as the exception from informed consent that make it challenging. But ROC actually in the first phase completed 3 randomized control trials. We did the ROC hypertonic saline study, we did the CPR feedback study, and we did the ROC prime study. And I'll go through these very quickly. So what was the ROC trauma study? We were interested in hypertonic resuscitation following traumatic injury. And this was a randomized placebo-controlled blinded study. And we basically looked at severely injured patients in shock or those with severe brain injury defined by GCS less than 8. Why were we doing this study? Well, there's some potential benefits. Hypertonic saline has been something that we've been all interested in. It's a smaller bag that has big combat advantage. It gives you more rapid restoration of perfusion, if you think that's important. It's been shown to reduce intracranial pressure, and that helps traumatic brain injury. And it's also been shown to potentially modulate inflammation that occurs after injury in organs like the lungs. And there were several trials in the past that had some positive results, but they were very small. And so we wanted to do a much larger study. And that was the first trauma study we did. So we entered very sick patients, those with severe shock, defined as noted here. And we also included those that had severe brain injury, defined by GCS of less than 8. And we looked at outcomes. Now, outcomes are important as well. When you do a randomized control trial, you want to look at meaningful outcomes. We want stuff that's meaningful to you and me. We want to look at survival when it comes to shock. And we also want to look at, when it comes to brain injury, good neurological function. Similarly with cardiac arrest, you'll see we want to see good neurological function. There's no point bringing someone back if they end up in a nursing home, care dependent for the rest of their lives. We want to have good outcomes. And so we've picked meaningful outcomes in the ROC randomized trials. So there were 3 arms to this. On the one side, they got our standard care, which was a 250 cc bag of normal saline. The middle group got hypertonic saline, 7.5% solution. And then the third group got hypertonic saline with dextran. Dextran is another thing that has been thought historically to help modulate inflammation as well as improve perfusion. You can see the outcomes. There was no difference. The 3 fluids actually were completely equivalent in terms of outcomes when it came to the shock group. You can see the survival rates were all not statistically different. They're all about 75%. And when we looked at the brain group, we had the same thing. There was no difference. They were all the ones with good neurological outcomes all had pretty good survival rates. So it was all between 52 and 54%. So this was the largest trial ever done of hypertonic saline, close to 2,000 patients, not showing any difference between any of the outcomes. Why were we not able to show? There are several reasons. One is maybe there is no difference, which is what we think. But secondly, other things may have influenced it. One of the things we didn't control for in this study, which some of the trauma surgeons have talked about, is we gave the 250, but then we allowed standard fluid resuscitation as opposed to controlling that. And that's kind of setting us up for one of the next studies that ROC is going to do, which is called the hyporesus study, which will actually look at actually controlling fluid itself in the first place, as opposed to allowing uncontrolled fluid therapy. The next study was the CPR feedback study. How many of you use CPR feedback in your EMS systems? Anybody have? So I was convinced, when I saw this 6 years ago, I was convinced that this was going to be the holy grail. So I had when we went to the Philips devices and we had this, I wanted this feature. I wanted the real-time CPR so they could see it and they could see that how they were doing, and this would make a difference. I was convinced. This was my bias. We actually did a study looking at turning this on a random basis and turning it off on a random basis. So sometimes it would pop up and sometimes it wouldn't. And you would, I was convinced. I was shocked. This study actually showed that the CPR off group, feedback off group, did better. There's no statistical difference, but you look at the outcome. It was 12.3 in terms of survival versus 10.6. It's not statistically different, but it basically showed no difference. Now, if you're investing in equipment, that becomes a big issue. That's an extra $4,000 or $5,000 investment you have to make. And you can see that there was no difference. Now, I will tell you, though, that the systems that participated in this were pretty good systems. There was Seattle King County, it was Pittsburgh, and there was one from Canada. So there's a small group of EMS systems. It was not done ROC-wide. And so it doesn't just generalize to everybody, but at least in high-performing systems, and those were 2 of the high-performing systems that contributed most of the data, the feedback didn't seem to make much of a difference. Now, if you have a system in which you only respond to maybe 10 cardiac arrests in a year versus 10 a week, there may be a difference, and maybe CPR feedback works there. It's also a great training aid, so I think that it has some value. But I think it shows you, again, the questions I said earlier. Question yourself constantly. We do a lot of things that none of us know are actually, whether they work or not, or whether they are doing what they're intended to do. But if you don't ask that question, you'll never know the answer. The last study I'll cover briefly is the ROC Prime study, and then Ron's going to take over. The ROC Prime study was a cardiac arrest study trying to answer 2 questions. First, does it matter if you do some CPR, how much CPR you do before you actually look at the rhythm and decide to defibrillate or not? And secondly, if you do CPR with an ITD, does it make a difference or not? How many of you have ITDs on your cardiac arrest systems right now? Just a couple of hands, okay. And this study was done largely because the question of the ITD had come up as to whether it was effective or not, and because we wanted to actually combine efforts, we were able to do what's called a factorial trial. You can do 2 studies in one. It's complicated for us as well as for EMS to actually conduct 2 studies as we found, but it actually helped answer 2 questions. Again, just to point out that the meaningful outcomes we were looking for were neurological function on discharge, and we were interested in also survival of the discharge as well as survival of the hospital, but they were secondary outcomes. So let's talk about analyze early, analyze late. So we think that if you prep the heart a little bit, it might make it more responsive to defibrillation. That's the theory that we've had. And there have been some trials that have shown that to be effective, but there have been also some other trials, particularly ones from Australia, that have shown to be not successful. So pre-prepping the heart for 2 minutes didn't make a difference in Australia, but it seemed to make a difference in Seattle, King County. So the 2005 guidelines said do it, then the 2010 said maybe there's not enough evidence. And so basically that was the impetus to do this phase of the ROC prime study. So this was a cluster randomized study. Now remember, all of these folks got CPR. The only difference was some got 30 seconds of CPR, while others got 3 minutes of CPR. Those are the two comparison groups. So we're not saying do no CPR before analysis. What we're saying is we need to do a little bit, or should you do a lot? And that was the question. The second thing we're interested in was the ITD. So the ITD is a little valve device that fits actually on a face mask or an advanced airway. And the idea is that it enhances negative intrathoracic pressure, improving blood flow to the heart so that your compressions are more effective. So remember, when you compress the heart and you compress the chest, you move blood through to the brain and other vital organs. When you release, blood comes back completely. You got to release completely. That's the importance of complete recoil. And essentially, you get blood coming back so that with the next compression, you can actually, again, push blood forward to your vital organs. What the ITD does is basically sits on top and enhances that vacuum that's created. And by doing so, sucks more blood back in. That's the theory. It's got good animal data to support it. And that was the idea behind it. It could be applied to the face mask or the airway. These are the study results. They will be published at the end of this month. September 1st is the publication date of the New England Journal. There'll be 2 papers, one on the analyze early, one on the analyze late, and one on the ITD. There was no difference in outcome. Now, this has huge public health impact. The ITD costs $100. I estimated just from my community, if we had invested in ITDs, we see 1,000 cardiac arrests in the Portland metro region. We would have spent probably $1 million in the next 10 years on technology that at least didn't work. Now, there's another paper that was published on the ITD looking at something called the rescue trial, where they looked at something called a cardio pump combined with the ITD. In that study, the combination seemed to make a difference, but we don't know which part of the combination was more important. Was it the pump, was it the ITD, or was it the two together? Okay? That study was also industry funded. You need to remember that. So industry has a bias. Keep that in mind. When they want you to buy something, they want you to do something, you got to think about that, right? I'm going to stop at this point unless there's some questions and turn it over to Ron, who's going to carry on to the next phase. Thank you.
Test. Thanks, Will. So any questions so far? Everybody still awake? So where are we going? What's happening right now? So in our system, for example, we're preparing to do some of these trials, and I'm going to make mention of them and see what the purpose is now. So we've had some benefits of looking at these other trials. Some of the paramedics in our system where we did all this work and they didn't really tell us much that'll make our system better, but it also let us appreciate that there was no point in investing in some new equipment. What's the next step? These were ones that were proposed. We have principal investigators at all these different sites. These are renowned physicians that have met and decided that, hey, let's look at this, and that's where we're going. So we're going to look at these different areas. One's going to compare continual chest compressions to 30-2. Right now, Vancouver, Seattle, and San Diego do non-stop chest compressions. They don't do 30-2 prior to intubation. Everybody else does 30-2. Has there been a difference? And we'll look a little bit at that. ALPS is going to compare the use of antiarrhythmic drugs. BLAST is a way of maybe measuring the status of a patient when they're in hypovolemic shock. And the last one is hyporesus, which means how much fluid we should give. So which is the one we can do advance?
Page down.
Okay, thanks. So
You went page up, I think.
Thank you. So we're starting by looking at how effective CPR is. I remember, Ron, CPR doesn't do anything. It's how fast you get the AED on. All this CPR is a bunch of gobbledygook, and now we're going back, well, actually it does. And it's important that we start it as soon as possible and that we do it effectively. Well, in our system, it's really bad. And again, I'm from the British Columbia area. We have 7,000 firefighters and 3,400 paramedics. We're finding that I'm now taking these mannequins around and finding that performance of CPR isn't great. Yet, the focus was on getting these AEDs on people. And, oh, we can do CPR. We've been doing it for ages. How often do you train in CPR? Oh, once every 5 years. Just curious, anybody here in this system do CPR training less than every year? I mean, less than every year in your system? Put your hands up. In other words, you all do it annually in the systems you're from. Does anybody do it less frequently than that? Put your hands up. That's good, so a few. Okay. And now the question is it important? We'll talk a bit about that. So, the theory before was, you know, we used to do 15 to 2 and 5 to 1, and we thought that was necessary, that was all that was needed. But then there was some studies that were done to show that when you do 15, it took you almost 10 compressions before you have appropriate coronary and cerebral blood flow to provide appropriate perfusion. So on this picture here, it was showing that the pressure needed at 50, it took almost 15 compressions. So the pointer is where again, sorry? Thank you. So it showed that as we begin to thrust, these are each compressions. Many of you might have seen this. It took a while before we even achieved that. So out of 15 compressions, really the only last 5 were of any benefit. Then we'd stop, wham, lose all our pressure, and blow in 2 breaths and start all over again to climb up to that level. Well, my goodness, why don't we do 30 to 2? It'll even be better. Well, when I was actually writing this program for our system, I got hold of my friend Jonathan Larson in Seattle, and I said, so you already do 30 to 2? Of course, we're not a fire-based system, although we have lots of fire departments involved with us. He jokingly said to me, well, we're a bunch of firefighters. We can't keep counting to 30 over and over again. He was joking, of course. He said, no, we're better. He said, we're not even going to stop. We're just going to push nonstop. I said, but how do you get breaths in if you push nonstop? That works. So I lay myself on the ground, and I put people sit on my chest and put weights on me. I expired all my air, like somebody was compressing on me. And I said, try and ventilate me, and they could. So we were convinced, and we went to nonstop compressions. This drop in coronary and cerebral perfusion pressure that we get in a normal 30 to 2, we weren't going to get. So this seemed like the obvious win. So anecdotally, talking to Seattle and then Steve's area from King County, what were the results? What do you mean? Well, actually, King County, which surrounds Seattle, does 30 to 2. We were doing nonstop, and so was Seattle. So I talked to my buddy Jonathan. He said, you know what, Ron, we're not seeing much of a difference. Here, we thought it was so obvious that nonstop was going to keep blood flowing way better, but we're not seeing a big difference. So that's the next trial. The next trial is going to be for 6 months or whatever. The people in the study will be doing nonstop compressions, then they'll switch, and they'll go back to do 30 to 2. There's more theory behind this that I'll talk about in a bit, but at the moment, we're confused as to why one wouldn't be better than the other. Any questions about that? Other trial, ALPS, Amiodarone Lidocaine Placebo Study. Well, when I started in the ambulance service back in I don't want to tell you, we were all giving lidocaine to everybody. It was the antiarrhythmic of choice. And then in 2000, this is an anecdotal comment, it seemed that the Amiodarone company funded a big conference and helped fund the American Heart Association building, and all of a sudden we started using Amiodarone. Was there any evidence to support its use? Well, apparently there had been evidence in responsive patients for controlling dysrhythmias, but nothing in cardiac arrests. So remember, this is a not-for-profit organization, as in ROC. So we've chosen now, or the principal investigator said, let's look at this stuff. Amiodarone has side effects. Lidocaine, some people don't like. We don't even really know if any of them make a big difference, so we're going to do a study where you're going to be handed a syringe as a provider of that, an ALS paramedic probably, and you're going to instill. You're not going to know what's in there. It'll either be amiodarone or lidocaine or absolutely nothing, just a placebo. And maybe we've been spending all this money and all these drugs needlessly for years, so that's the next trial. Most of the paramedics are thrilled about it because they all have their own biases. Oh, I hate lidocaine. Okay, if we're going to compare both, listen, I have no problem. Because some of them, of course, are like, we're doing another study, but when I explain the benefits of it, most of them buy in. So what will happen quickly is that you'll be given 3 syringes. 2 will be administered as your first dose. The 3rd will be your 3rd dose. You don't know what's in that. So you must have at least provided 1 shock. So we're looking at VFib, VTAC patients. When that person goes back into that dysrhythmia, we'll then give the 2 syringes. If they recur, it goes back into VFib or VTAC again, then we'll give the 3rd syringe. And then there's also things to consider, well, when they get to the hospital and the doctor wants to do something else, well, it's going to be communicated to them. They can make a phone call to find what's been done, or it's going to be realized that the dose we've given, it won't even hurt to follow up with some of the same antiarrhythmics. Simple. Adults that are in VFib and VTAC. Biomarker lactate for what? Assessment of shock trauma. What's all this about? So, meemaw, meemaw, meemaw. You all can relate to that. I respond to a car accident. Here's a car about 2/3 of its normal size. I'm going, my God, where's the person out of this car? I was second on the scene. The fire crew's there first, and the RCMP or the police are pointing, and he's standing over there. Here's this guy standing there looking happy. He's in his 20s. I said, are you hurt? No, I'm fine. He's jumping around. I said, but your car is destroyed. Oh, I know. Aren't these cars amazing? I'm just great. I said, yeah, but look at the mech. You got to go to the hospital. No, I don't want to go to the hospital. In fact, I got to go to the bathroom. Cars are winging by. I said, look, can you wait? No, I can't. So he pulls it out and starts to urinate. Must have done it for about 10 minutes, we figure. We were in stitches. We're laughing so hard. We thought this was Austin Powers all over again. He's being, and then he comes out of it, and I said, look, you got to go to the hospital. No, you're not strapping me to no backboard or nothing. I don't want to go. I'm fine. So we finally convince him, and he goes in the regular ambulance down to the hospital. He walks into the emerge. Hi, what happened to you? Oh, I was in a, smucked my car up a bit. We're saying to him, we can't take a picture in our system that his car was destroyed. So that goes to the triage nurse. It gets passed down the line. He's put in a hospital bed, dead in 2 or 3 hours. They didn't appreciate the severity of injury. They had nothing to indicate that to him. Oh, he was a bit tachycardic, but he was compensating fine, and it wasn't a worry. Now, if there was some better way to label this, what do we rely on, as I'm sure most of you do? Mechanism of injury, vital signs, and apparent injuries. Well, his vital signs weren't alarming. His apparent, because he was compensating, his mechanism of injury was, they didn't appreciate that, and any obvious injuries weren't there. So what can we do? Well, now they've said, if you take a drop of somebody's venous blood and you put it on an indicator strip, if you're losing blood, there's an indicator of that by an elevated lactate. And you can see it, like taking a blood sugar, but this time it has to be venous. So as paramedics, we could take a drop of this and show it at the scene to be a certain level. And again, at the hospital, and if it's, one, been elevated to begin with, or it's a big change by the time we get to the hospital, those alarm bells will go off, and the complacency, which might be normally in the emergency, will be way different, because they've got something concrete. Do we know this is for sure? Well, we had suspicions about these previous trials that they would be great. Well, we don't know yet, but it's going to be a trial that's happening. So sites are already doing it. Our flight medics are doing it. I actually got hold of our EMS system and said, you know, it's not fair just to give the fly guys doing it. The paramedics on the street want to do it too. So we have this a system called Profit that we'll talk about that actually maps out the kind of trauma that everybody's doing now, and we can determine which stations are doing more of it. So they're now being included too. Hyporesus. Mo talked about this. Well, we've been giving all this fluid. So anecdotally, a trauma surgeon friend of mine said, you know, I get these people in, they were brought in by the paramedics, and they dump a bunch of normal saline into them, trying to keep their blood pressure to 90, and it's like pink Kool-Aid coming out of them. It's decreased coagulopathy. Well, Mo's alluded to all the problems that occur, and we're not helping these people. We've got to find a better way. And we've been focusing on this blood pressure of 90, but do we even need that? So now there's going to be this trial where we're going to have the standard arm, which is dumping normal saline in them to keep their blood pressure to 90, or we're going to do it to 70. And we're only going to hang bags of 250, so it's more difficult to administer more fluid, and that's what we're going to focus on. We're thinking that the volume is causing problems, that by giving less, we can increase the person's chances. Anything you wanted to add to that, Mo? So are we getting it done? Are we getting it done? So I already made reference about how effective are we. We're going to measure this. We're trying to find some more new trials that are coming up. We're trying to focus on these key aspects still, and I'm going to talk to you a little bit about this in a second, but we're all hopefully really familiar with all this. Is our rate appropriate? Is our depth appropriate? How many right now in your EMS systems or fire systems actually measure the depth of compressions your paramedics perform on a recording mannequin? Put your hands up if you do. So not too many, not too many. We haven't been for years. I took a recording doll around to 500 paramedics, had them push on it. I would say about 80% of them didn't do it properly. This blows us away. So we've now invested in a whole bunch of these things because they never shown, they had these wonderful examiners watching their effectiveness of compressions, but it wasn't being calculated. Now they're seeing in black and white if their CPR is effective or not. We have 2 of them up here. We're going to give people a chance to come up and do this in a second. So what's coming up? These are things that aren't happening right now. These are potential trials that could be happening in the near future. These are all of them. Hypoxemia trials and cardiac arrest and trauma. Looking at oxygen. Vasopressor. Do we need to give this person epi or not? Has there ever been a trial on it? Well, apparently there have been some. There's been one tried in Australia, and there was concern about, and Mo can correct me on this if I'm wrong, but there was some potential bias because some of these paramedics couldn't withhold the epi because it was all been shown to be used, and you don't want me to give this? Effective EMS advanced airway management. We're always debating, do we need this advanced airway or not? What about positive pressure ventilation? Do we need to do lots of it or less of it, or are we doing too much of it? Estrogen. You want to give hormones? And a metronome. So let's go through them quickly. 2 trials that are going to start. You can read through all the experimental models in ischemia reperfusion suggest that excess oxygen in the initial minutes following the return of spontaneous circulation results in the rapid production of reactive oxygen species. This would suggest that controlling oxygen levels prior to return of spontaneous circulation may be important. In addition, most ICU protocols recommend rapid titration of FiO2 to 0.4. Thus, the time period during which out-of-hospital cardiac arrest victims are most likely to be exposed to excess oxygen includes the pre-hospital and emergency phases of care. We've always been dumping all this O2 into these people, and it may be harming them, is what we're seeing. So, another one, an observational analysis from the San Diego County Trauma Registry suggests increased mortality. More people were dying with either hypoxemia, not enough, or hyperoxemia on arrival at the trauma center. The potential harmful effects of hypoxemia in traumatic brain injury are consistent with observations in cardiac arrest, stroke, and neonatal resuscitation. Objective, to determine the outcome effects of controlled versus maximal oxygen delivery in major trauma victims undergoing pre-hospital insertion of an advanced airway. So we're going to be careful how we give oxygen. That's never really been that much of an issue. You probably read about this too, or you don't want to go higher than 90% or whatever, or sorry, 97%. We're going to look at epi. One site's going to say, we've been given epi all these years, and of course they're calling it a vasopressor. It's the generalized term for it. Is it of any value? And by the way, the picture, it's a bit of a plug. There's the Resuscitation Fellowship that happens in Seattle that any EMS person can go to if they wish. It's where many people here have sort of got their roots, and I've spent my time down there. It was wonderful. They tell you why their system works so well when it comes to cardiac arrest, and it helps improve your performance. That's the picture on the right. That's the first academy that I got a chance to partake in. So the few trials that exist are limited and do not demonstrate any benefit to survival or discharge. We're talking about with epi, so we're potentially going to do that in the future. Proposed intervention. Subjects with cardiac arrest persisting after one shock or after a rhythm check identifies a non-shockable rhythm will receive the study drug every 3 to 5 minutes. The study drug will be placebo saline or epi. Study drug can be administered via intravenous route or IO. This is the last one. I swear by intubation. I intubate all the time. It's what defines my practice. I'm an advanced care paramedic because I can intubate. Right, well, I can do other things too. But you know what it's like. Oh my God, here the lesser trained people come, well, these guys can intubate, right? Little I know that it may be harming the patient more than it's benefiting the patient, but that's an aside. And really, it's probably more of a timing issue because we used to stop everything. I'm going to intubate, right? Stop compression, stop everything. And now I think back and go, oh my God, I actually produced a video way back in 2006 showing that time on the chest. In the old way, we were on the chest about 22% of the time when it came to intubation and stopping to look at dysrhythmias, etc. The new way, we're on 92% of the time. And here's an aside for you. The last 2 cardiac arrests I've run, ready for this? I've talked to Mr. Pepe about this. I've never taken my hands off the chest for all defibrillations. So 360 watts times 8 times with a pair of rubber gloves, never felt a thing. Compressed right through them all. I'm not telling you to do that. 2 physicians had done a study on that, saying it wasn't a problem. The first time I did it, I went, oh my God, put my finger in the middle of the chest. Oh my God, I didn't feel anything. The next time I put my hand there, I did. So then I said, so I was interested. I was doing this, and the fire captain said, look out of the way, Sonny. I want to show my guys I can do it too. So he was in there too and did it. And then the female paramedic I was working with said, well, I'm not going to be outdone. So she was in there, and we all pushed and never felt a thing. Right? So maybe that's the next. Remember, we don't want these peri-shock pauses. You don't want to stop before you compress. Maybe we can just do it right through it. So does it improve survival to hospital discharge? Does it improve survival? This is airway. To hospital admission, you can see all of these yourself. We're questioning the value of intubation. And we've got to be careful what we're looking at here. People say, oh, it doesn't provide the benefit, but maybe it's the result of how we're administering intubation as opposed to the actual intubation itself or airway control. What about Arizona? Yeah, how many of you have heard about the Arizona stuff? Anybody heard about that? A few of you have. So in Arizona, they said, we don't even need to ventilate somebody. For the first 6 minutes, we're just going to push. Oh, we're going to put a non-rebreather, we're going to put an oral airway in them and a non-rebreather oxygen mask on them and let it hiss at 15 liters. And we think that's ample, that with your compressions, we'll move air in and out, and it'll save more lives. And you know what? I was psyched when I read this article. I went to my physician in charge, Dr. Jim Christians. I said, look at this. They've doubled their survival. He said, yeah, but look, they were doing 50 to 2 before. And now that they've doubled their survival is still half of ours. So it shows you you got to look at some of this research. Things look amazing, but they may not be as amazing as it seems. But it's still that question. So maybe a trial coming up might be, we're going to compare 30 to 2 to nonstop, but one of the proposed trials will be, let's try nonstop with varying amounts of ventilation. Maybe ventilating every 10 seconds is an issue. So if we look on this, that's how it was done. And I sort of just mentioned this already. In cardiac arrest due to sudden arrhythmia, the most common scenario, arterial blood is initially fully oxygenated. Oxygen content declines over the period of several minutes during CPR as blood is circulated more slowly to tissues that are not as metabolically active. Positive pressure within the thoracic cavity due to assisted ventilations reduces venous return and forward blood flow in low flow states like CPR. So let me think. With 30 to 2, there's 30 times of compressions with no ventilation, so that's not impeding as much venous return. But in nonstop, every 10 compressions, I'm going whoosh into the chest, whoosh, and I'm putting pressure in the chest, which might impede blood return. So maybe this nonstop thing was supposed to be so good that's now been questioned because King County's survival is equal to Seattle's, and they're comparing the methods. Maybe it's also to do with ventilation. Maybe this nonstop compression method, the problem with it is we're ventilating more frequently. And maybe if we ventilated less frequently, it would save more lives. So that's a question, this potential trial that's coming out. So negative pressure within the thoracic cavity due to agonal breathing enhances blood flow. So we've probably heard that. Hey, if you get to the guy, I all the time when I'm teaching fall to the ground, have a hypoxic seizure, and take agonal breaths. Somebody even stuck me on YouTube, apparently. You can look it up under agonal breaths. I'm not proud of it. It wasn't a very good example. But the point was, all our paramedics realize that if somebody's breathing, it doesn't mean they're alive. And we all, most of you, I'm sure if not all of you, realize right away, if you walk in the room and there's somebody gasping, that they need more than just observation and assisted ventilations. Chest compressions can move air and result in ventilation when the airway is open, a situation analogous to high-frequency ventilation. So anyways, hypoxic arterial blood may not necessary, but may be harmful in post-ischemic cellular recovery. Hyperoxic, so we've talked about that already. So what we're going to do is limit ventilations and determine what the optimal ventilation frequency is when performing CPR. By right now, 30 to 2. Apparently there's some places that are doing 100 to 2 in Europe. What is the optimal? Or if we're doing non-stop and blowing a breath every 10 compressions, maybe it could be less. We're going to give hormones. You're going to give what? All my paramedics are freaking out. You mean I'm going to start growing breasts? I said, no. This is a single dose of estrogen. But it's been shown that young women survived cardiac arrest and trauma better than men. And that there's a small trial going on in San Diego right now, a preliminary trial, and if it shows to be of benefit in both of these, potentially we're going to give a dose of estrogen. Rapid administration, you've read all this, I'm not going to go through that. Female sex hormones appear to give women better resiliency to extreme injury, while male sex hormones seem to worsen their survival after trauma. Study leader Dr. Hayter says, after an assistant professor of surgery said in Hopkins' new release, if we can find a way to manipulate those hormones in men, for example, by temporarily blocking sex hormones, we may be able to improve their survival. Again, it's temporary. So this is either IV or IO, and we give them a dose. Again, this isn't happening. This is a preliminary trial going on, but this could happen with rock in the future. So everybody stand up, please. I want you to push on the table, and when I say start, you're going to count. You're now going to do CPR for me. Oh, there's no cushy mannequin to push on, but I want to look at timing now. So I'm going to say start compressions, and I'm going to say stop, and I want you to have counted to yourself how many compressions you've done. You guys ready? And go. Top. So you just push for 10 seconds. How many times are you supposed to be pushing a minute? 100. So How many times is 10 going? It goes into 1/6. Actually, I'm going to do one more time. I'm sorry, my mistake. Push one more time. Sorry. My math's bad. Here we go. Ready and go. We're going for... I just had to get you to warm up, you know. This is getting you warmed up for these mannequins. Keep pushing. Stop. So, that was for 15 seconds. How many should I have done? Should have done a quarter, so I should have done 25. 25. Hands up if you did 25. We're all going to put your hands up. There's issues about that. Actually, they're now saying you can go slightly faster than that. You can all have a seat. You should be pushing between 100 to 120 times a minute. And there's actually a study going to be coming up that's going to check compression frequency to see what the optimal rate is. Again, I've done 500 paramedics. Do you think I find them going too fast or too slow most often?
Too fast.
Too fast, right? I heard down in Dr. Pepe's area, there were some of them compressing way up there. Is that right?
San Diego.
San Diego? I'm sorry. And it was like 150 or something like that? Thank you. San Diego. They had to deal with that. So, I don't know how often that's evaluated. Again, I took these recording mannequins around to try doing that. So what I want to do right now is pick two people. We're going to get this actually demonstrated up here on the screen. We're going to see and we're going to watch this. And others can try it out later. So, who am I going to pick? Are either of you practicing CMS providers? One section adults. Okay. Now I'm going to take you, sir. Come up pushing this doll funnel. Yep.
Dan Davis's work. Dan Davis's work on the hyperoxia.
I'm going to get you to go to that doll right there. It can't be sexist here. I got to pick one of each, right? And you can go to that mannequin over there.
That was the Hopkins
Can you come up and
study,
get these
so it was Hader from Hopkins.
So what we're going to do is right now put on the screen the performance of one, and we're going to record the performance of the other. So I'm just going to escape out of this.
What he was talking about. I think he was using slides that Jane had put together.
It's all yours to.
We cut out a bunch of stuff because of time constraints.
So you're going to watch them perform CPR. I'm going to have them do continual chest compressions. So I'm actually going to get two other volunteers. You want to come up here? You didn't volunteer. I want you to ventilate. And who else can I grab? You want to come up and ventilate for me? Sure, please. So all you have to just grab a bag valve mask. What I want you to try doing is non-stop compressions. I'm not going to make you go forever. So you're going to go count, and every time you get close to 10, 8, 9, 10, the other person's going to ventilate. That's the new trial. It's going to be non-stop compressions. You never stop to allow the air to go in. You just keep going. The person at the head who's ventilating will ventilate on 10 or approximately at that time. Do they have to time it to blow in on the chest uprise? No. They just got to do their best to get it in. So do you understand how that works? Yes. You understand how that works? You'll never stop pushing. Okay? You ready to go? The 200 counters, yeah. Tell me when you're ready to go. Okay, go ahead and start. We turn that on too here. So that's actually showing what's going on up there, if you want to look at it. Okay, you guys can stop. That's great. I don't want to tire you all out. Thank you very much for that. Okay, lessons to be learned, and we'll see. I've now done this to 500 paramedics. They've all been told they've got to push harder and deeper. I'm yet to find somebody who weighs 130 pounds or less that can do CPR anymore. What? We have small people on ambulance. Some of the outlying communities, they're by themselves for a long time. I find people that are 250 pounds that don't push deep enough. So can you put the summary up there for us? Where is it? So what this is measured, if you look up here, is it's measured ventilations. And I've created 400 to 500 Cs per breath, and it's measured depth of compression. So the compressions, how many of them were deep enough? 2 out of 51. 2 out of 51. And she was pushing pretty hard. She's looking at her eyes. They just about came out of her head. You know what? I see this all the time. So we're going to get a chance to try this. I'm seeing so many paramedics not pushing hard enough. Oh, but the new standards are 2 inches plus. No, you got to push bloody hard. So if I was going to compress this doll, just watch how I compress a doll now. That's a lot harder than what she was doing. And why? Because I've figured this out from doing this. Now, maybe I'm a bit overzealous here, but you got to push a lot harder. And most paramedics are, oh my God, especially some of the big guys, I'm scared about pushing too hard. And again, it's not how hard you push, it's the depth. You're wanting to go 2 inches plus. So you get somebody who weighs 90 pounds, you're not having to push as hard. But if that was a 200-pound patient, you're going to have to push harder. And it blows me away. As I said, 80% of the paramedics that I've gone to with this don't push hard enough. How many of you did I ask measure to get this measured? Not very much. Most of it, you make a light come on. Or the person looks at you. And you'd be surprised if the new way of doing it is effective. If I'm in the emerge and there's an arrest in there and we're asked to go up on the table and push, and we have smaller nurses up there, they're not even creating blood pressures or anything. Now again, is there evidence to say this is huge? No, but we're anticipating that we think it's important and the depth is important. So that's why the standards have changed to not 1.5 to 2, but a 2 inches plus. Thank you. And we'll get a chance to try this again if we have a chance. Yeah, let me just grab this again. I think I'm almost through, then it's Steve's turn.
The other one might be a printout, right? The other one's a printout, yeah.
You got the wrong clicker? Maybe I grabbed the wrong one. Oh, well, just do this one. So, we're now going to question what the appropriate rate should be. They've said 100. Now it's 100 plus. Well, when is it too much? So there's a potential study coming up with ROC that's going to compare 100 versus 120. There is some preliminary work to indicate that rate of compressions does make a difference. I'm just going to put these up quick and we can talk about them. For us to even do these studies, we've got to have paramedics that are willing, and secondly, your systems have got to be prepared to do them. So, ROC EMS, ROC, I realized a few years back when they brought me on board was, you know what? There are some systems that the paramedics don't even want to play the game. What do we have to do to get them to play the game? So I said, we've got to involve us more. So there's now representatives from each site that come in and sit on a committee. These are other paramedics or firefighters that sit on a committee and discuss. And some of them are like, yeah, listen, our guys aren't playing this game. You want us to do that trial? I'm like, nice, try. And they're listening because there's no way this research is going to happen if the paramedics or the firefighters won't play the game. And sometimes it's a matter of logistical stuff, like can we actually physically do this trial? No, it won't work in our system. This is the way our crews are manned, this is what happens, and that's why that's happened. While there are regular teleconferences with others aforementioned, now communication between sites, which is what I've just mentioned, with representatives in the field, study providers are included. So we're not just taking administrators, we're saying to be on this committee, you must have practicing paramedics or practicing firefighters that are out there doing it. So at least that they can take it out and say, yes, it actually works. I don't want to do research. Do I get paid more money for it? Hey man, this takes up more effort on my part. What's the value of doing this? That's huge problems I had in my system and other systems. If you look at Seattle, they have these things called levies. And you can correct me if I'm wrong, Steve. And levies are things that the voters vote on every so many years. And they also will vote on whether paramedics deserve more money. So hey, if I can show through research that we're a better system, the voters are more willing to provide us more income. I wish that was the way our system is, but it isn't. So now we're having to compete, tell paramedics, oh, but this is all by management, right? It's management that wants to read this research. Well, in fact, our management doesn't even like it because it costs them more time and effort. It's better defining what we do on the street. It makes us better paramedics. It's not based on eminence-based medicine. It's what actually works, and we can now determine what that is. So there it is. So research in the field environment is new and could be added meaningful tasks to undertake. Fire and EMS that can see the benefits of research and how it can better shape and direct their practice towards the ultimate goal of saving lives and improving outcomes are more likely to participate. We're finding we weren't getting back to them enough. Oh, you're going to do this trial. So I've now been sent to go out into the field and talk to everybody. Oh my God, finally. We did all these bloody trials. Nobody's told us how they did it. All we know is they did a bunch more work and filled out a bunch more paperwork. Well, we have to actually, I'm going around face to face and meeting them all and saying, you know this effort you've done, these are the results. Well, thank goodness. Now I know why I'm doing this stuff. Research can qualify what they do and may challenge tradition or habit. Regular reporting and feedback to the providers encourage participation in research. As Steve will get to, if you get feedback, it's huge. I got a report on this last cardiac arrest I ran. It doesn't tell me I'm good or bad, it just tells me all the factual stuff. And Steve will go through all that. So again, we're not saying this is easy, but we're saying it's worthwhile. How do we motivate these people? So I'm driving around to all these paramedics and I have a pocket full of coffee cards. I get to them when they're on the job. I'll say, hey, can I take up your time for a minute? You mean I don't have to do calls? I said, no, I can't stop that. But if you listen to me for half an hour or 3/4 of an hour and we talk about why you're doing this stuff, nobody's ever told this to me. They just give us a memo and nobody ever reads memos. If I explain it to them and then they get a coffee card out of it, they even get a CME credit out of it, it's worthwhile to them. And this, I don't mind participating now. I can see how that will help me as a paramedic or as a firefighter. I'm done. Steve, your turn.
Well, I tell you what, I'm going to start compressing through defibrillation if I can have your kind of energy. Okay. So again, I'm going to speak to quality assurance, but I'd like to speak to the labor side of it too. So if you guys have any questions about that, I'm happy to hang out afterwards and go ahead and yell stuff out in the middle too if you'd like. Who in here is a member of a ROC agency? Say, okay, so we have a handful of folks that know what we're talking about. And have you guys had any challenges, labor-wise? Yes. Yes? Yes. Have you been able to overcome them, or?
We've worked through some of them. I think the biggest question is does ROC or Little Rock provide some sort of funding for the training of our paramedics to participate in there? And then the added workload that it comes on, that's been an issue over the years.
Okay. You guys? Nothing? Okay. I'm real fortunate where I work and where these guys work and where I'm from and Dr. Pepe came from, and that it's, Seattle King County is a very organically grown system. It's not like you can just decide you're going to start something like this and put things into place. Because what are all our guys going to do if you just tell them that here's what we're going to do? No, we're going to talk about this a little bit. So for us, it's cultural, and everybody in our community gets them. When we get our job, it's an understanding that we're going to be involved in research and projects. It's just kind of a way of our life, and we're very fortunate in that regard. But what I can say to you guys, anybody having labor issues with it or any kind of pushback is, especially in today's economy, I think paying it forward a little bit is worthwhile. Because when you guys go back to float your bonds, pass your levies, whatever it is or however it is you fund your system, Dr. Pepe kind of alluded to it earlier today, you have something to show for yourself. Why? Why do you guys want more money? Why do you need more money to operate your department or add an aid car or a medic unit? You can give them the hard numbers. So just a little tidbit there. Dr. Kopis, I sat in a lecture here a couple months ago, and actually it was part of our Resuscitation Academy, which Ron spoke to a little bit. I will say that's a program, it's roughly a week long, 3 or 4 days, and it's kind of a soup to nuts demonstration of our system. And I'll talk about it a little bit there. What I will say is it's a no cost to the employee. All you guys got to do is get there. Your department gets you there. Tuition and everything, is all covered. So that's kind of a cool thing. So anyway, so we're sitting in there, and I'd already put my presentation together, and Dr. Kopis starts talking about firefighters and paramedics as cattle. We're relatively intelligent, but we can be, with strong leadership, we can be steered in any given direction, and we'll generally do what we're told. And so I'm sitting in the back room, like, he just called me a cow, But you have to see the humor in it. So I manipulated my presentation a little bit. I like to think of it as more of goalies. I don't know anybody in here that likes hockey or plays hockey, but I don't think goalies are terribly intelligent. I mean, they got to be a little bit crazy, right? I mean, to stand in front of this vulcanized piece of rubber coming at them at 100 miles an hour, and they do it over and over and over again. What they do, though, is they love their job, and they strive for excellence. They keep coming back. You know, a perfect day to them is a shutout. Do they always get it? No, but they're always working to improve. So it's a little more glamorous than a cow. And I hit both coasts and both countries, so I hope I didn't offend anybody. We all love our job. And I think none of us go to work expecting to make a mistake or error. It happens. I mean, look what we're dealing with. You know, so what we do is we identify those areas so that next time we're presented with a similar obstacle, we can overcome it. So how do we look at it? 3 elements of good research. Be honest, organized, and thorough. Okay? Be honest, I think that's probably, I put that at the top for a reason. I mean, you want honest numbers because you want an honest reflection of your performance. But, you know, somebody like me or whoever's doing the QA, I think, and the person recipient of the message, so the firefighter or the paramedic, you know, we all need to be open to criticism. And we should expect honest feedback. If I screwed up, I want to know I screwed up. But when I'm offering feedback on the cardiac arrests, I also realize I've got 3 fingers pointed back at me. 1 out, 3 back. You know, and I don't know, I think it's appreciated. I haven't offended any of you guys lately, I don't think. Organization, you know, if you don't have a system in place, it almost seems insurmountable. It's like, where do you start? And you just have to kind of distill it out and pick a point, and then be willing to move forward and just slowly organize things, pull things into order. It can be as dynamic and fluid as you'd like it to be. And thorough, start to finish. I mean, your guys aren't going to buy into anything if you tell them you're going to start a program, and then all of a sudden, days, weeks, months later, you're not hearing any of the results back. Right? I mean, you got to get buy-in from the boots on the ground, and the best way to do that is show them what they've done with their participation. Something we did, we started doing a couple years ago down in San Diego, I think it was the first meeting we had with the EMS representatives, wasn't it? And that did quite a bit of good in starting the buy-in of the paramedics and the firefighters to the rock. We realized that they need us as much as we need them. So, and they were kind of astonished that we all wanted to hear the results of these studies. I mean, why not? And once we started getting the feedback out there, I mean, the participation just kind of continued to grow. So challenges, it's a lot like pushing sand uphill, or that boulder, as you can see. Eliciting teamwork. You know, we work better as a team, I think, on a regular basis than most other occupations do, because we recognize everybody has their role. What was it, A, B, C, D, and then the 5th guy, E, right? One of these guys lets up, or 2, they're going to just start going in circles. So teamwork is paramount. And that goes to all the individuals. Here's the one I was talking about. You know, we have a great job. We have good wages. We can, you know, who doesn't want more money, but we have good wages. We have a pension. Most of us work pretty nice schedules. They're great for family and everything else. But realize why we're here. And I have to do it. You know, I'll sit up on the edge of the bunk at 2 o'clock in the morning and just wonder, why the hell didn't I go into that computer science building in college? Most of those guys are probably retired by now. But you can see it all plays together. So strong medical direction, strong leadership, I think, is very worth mentioning. These 3 of our individuals, Dr. Kopus, Dr. Kudenchuk, he's one of the PIs from our area, and then Dr. Eisenberg's my medical director. You know, you got the aid cards, you got the guys on the truck. I mean, heck, we've got students. And then the guy, George Sofko up there in the middle, is an NIH representative, and he's leading this whole thing. So, and how many people in here see their medical director on a regular basis? Are you guys, are most people in here paramedics, or we have an assortment? You know, if you're lucky, you see that guy or gal all the time. Hopefully they're involved. Okay, so after our first academy or two, one of the feedback issues we got was, geez, we can't figure out how you guys, how are we supposed to start what you guys have? And so Jonathan Larson and I, we sat in a room and we're like, well, we really got to boil this down. Three components is what we came up with: data collection, compiling your data, quality assurance, and feedback. So, has everybody in here seen Office Space? You know, the TPS reports and the guy with the stapler running around in circles. Okay, that's this. And this is what I work on. That's where I work when I go downtown and do quality assurance. And I guarantee you, everybody in EMS thinks they're doing this. They walk around with their sweatshirts and the levy pads and high-fiving each other in the hallways. You know, we need them. And they are just as important as those of us in the living rooms and on the street corners. It truly is a team. We need them as much as they need us. Because what they can do, collect the data, and we are the data collectors. Every MRF you write, every piece of paper you tear off one of those recorders, or the machines that come in, the downloads, if you look at those, it's all data. They put it together, clean it up, and then give it to somebody like me, and I look through it, and then I think the most important piece, though, is getting it back out to the crews. You know, I mean, you can collect all the data you want, and you can study it all you want. I put a thing online a couple of years ago. One of those, yeah, I'm almost embarrassed to say it was one of those EMS forums, you know, and that people read every day. And hey, does anybody do QA on cardiac arrests? And you know, I got a number of replies back that, oh yeah, we get our Utstein numbers every year. And I'm thinking, gosh, what does that do for you? You know, and I look at our guys, and we get them back some form of communication as quickly as possible. Sometimes it's a week or two, sometimes it's a month, depends on how busy we are. For me, I only get to do it about 6 hours a week, so you know, they do tend to stack up. But some sort of feedback, even if it's practicing CPR in a beanery at lunchtime for 5 minutes and running a tape and seeing how you do. You know, it's worth it. I think it's worth pushing, and make it competitive. I mean, geez, we play hockey, softball, basketball. I mean, they got those games coming up next month. I mean, departments compete against departments, and houses compete against houses, crews against crews. I mean, we're a competitive bunch. So, you know, the feedback forms that my counterpart in Seattle does, she gives them this big stack of, I mean, it's probably 20 pages, and it's all the information. And what do you think the guys in the, well, the face page has kind of the bare bones statistics on it. Their CPR fraction, their rates, interruptions, and it's just 5 or 6 bullet points. That's the front page, and then there's all the rest behind it. What do you think the guys keep?
Front page.
Just the front page. And one of the stations downtown has got all the front pages on their bulletin boards back in their bunk room with circles on it, and hey, look what I did, and beat this, and that kind of thing. So quality assurance, not to settle for average, but identify your weaknesses. You know, nobody wants to be the guy fixing the truck, fixing the truck under the truck, right? You know, I can't emphasize it enough. Oh, I gotta have you guys out of here close on time. I've already asked that question. I think it's been answered. You know, you don't have to be doing research. You don't have to be a rock site. You know, but you will benefit your firefighters, your paramedics, and ultimately your community just by exercising a little bit. You know, that last slide, there was another part. Does somebody in here does downloads? CPR downloads? You guys do? You guys use voice recordings?
Yeah.
Philips and we have Philips and Medtronic in our community. I know Zoll has a very nice machine with some new software coming out as well. You know, if you guys have the ability to record voice, and this is one of the big stumbling blocks that we have, are the voice recordings, and people worried about legalities and am I going to get in trouble? You know, quality assurance is non-punitive. All it is an exercise to improve performance. And they have software, believe it or not, now that you can put on a laptop, you can download the case off of your computer, and you can watch it. There was a screen up earlier, I think, in Mo's presentation. It was the one of the, it looked like 3 pieces of a heart monitor with the rhythm on it. It's actually a still shot. It'll play like anything plays on a computer. You click play, and you start to see the rhythm come across the screen. You can watch impedance and compressions. If you have the voice module turned on, you can hear what's going on. So you can pick up all kinds of information. You know, but whether it's a patient's age, anything that might, you know, anything that somebody may have said, like in a report, that might not get written on the MRF. But it's all data. It can all be used. And it's terribly valuable. If you haven't had the opportunity to do it, I don't have the software on this computer. I usually have a case to play for you. But it's one of those things where you're watching, you're like, oh my God. So if you have the opportunity, get your rep out there to your department and have them show it to you. I think it's worthwhile. So why is it important? I think this whole time I've been highlighting on it. It can give you an idea of your system's performance. Most systems are measured by their success rate with cardiac arrest. It's like the one benchmark that everybody looks at and to improve on. You can boil it down to crew-specific performance. You can look at the individual if you want. Again, it's not to get anybody in trouble. And it will be a hard sell to your folks, but it's one of those things that you just kind of have to take a step forward and start using it and show them. You know, once again, I mean, if I made a mistake, how am I going to know unless someone tells me? And if it's only to help me out down the line, I think it's worthwhile. And that speaks straight to the feedback loop. Gosh, we get evaluated on everything. We get these, Dr. Kopus, all the Seattle guys and the students get these things called CMEs. You get a CME, you got to go see him. And he lets you know what you did right and what you did wrong. It's constructive. Sometimes it hurts a little bit. You walk away with a little less ass than you had before, but it'll grow back. You know, the QA, it can improve your continuity, I think, department-wide. If you work together as an entire community, county, parish, whatever you have, it can help. And then, you guys familiar with the Hawthorne effect? Ever heard of it? People tend to do better when they know they're being watched. So, it's something interesting to look up. So this is just a sample of the letter I send out. What happens is, after, and we're just now starting the ALS downloads. BLS downloads we've been doing forever. And, you know, it's something relatively finite. I mean, once you hit ALS, it gets kind of gray. But, you know, we can control compression rates. We've been talking about it all morning. Ventilations, we can manipulate it a little bit here and there. And when I took over, you know, it was just kind of looking at where can we improve now? And this is when we changed our CPR. You know, Hart rolled out the new guidelines. What was it, 2005? At least that's when we started with the 30 to 2 in 2 minutes. So for the first year, I would say it took to get compliance, 100%. And I'd say we were nearly 100% compliance after a year. But for a year, I was sending these letters back saying, hey, remember our chest compression rates are 100. You got to go for 2 minutes, not 1 minute. You know, and then they get to the point where they could watch them. So by seeing their own performance and then getting it written down, you know, people took notice. And then I kind of change around as we go. Lately, we've noticed, and the emphasis has been on interruptions. So I'll sit there with a stopwatch, listen and watch the thing, and time the interruptions. And I'll be darned if after about a year, We drill 4 times a year on defib or CPR evolutions, and then our instructors get a yearly update. And after about a year, our interruptions are down to almost nothing. Most of the guys will be able to identify before the machine is done identifying. And you know, actually, who in here does manual defib? Or do you guys all at the AED? Any BLS agencies? Yeah. We put on a manual defib class in Seattle one day, and they went up to the whiteboard in the beanery, and because one of the guys on the truck had asked about it. You know, is it really that difficult? I know we used to do it years and years ago. And they go, well, you guys want a quick class? And sure. So Norm draws on the whiteboard a sinus rhythm. He goes, here you have a sinus rhythm with no pulse. What do? You do CPR. Right on. And he draws VF, and one of the guys yells out, oh, just shock it. Shock it. He goes, okay. And then he draws asystole. How about this? CPR? Right. He goes, okay. Let's see how you guys do on your next alarm. And you know, and there's more to it than that, but the point was, it's only going to take you a second. It's not rocket science. And with a little practice and a little dedication and drilling, you can shorten up your pause, whether it's your initial analysis or the one, you know, around the shock, to 2 seconds, as opposed to the 12 that it's going to take the machine. Over the course of let's say somebody's in refractory VF, you do a number of different rhythm analysis at 12 seconds a pop. That's 12 seconds add up. I mean, pretty soon you're into a couple minutes of that resuscitation with no activity. So, you know, if we can work to shorten those up, we're going to be money ahead, especially with some of these exercises that we're looking at doing. So, you know, teamwork and buy-in, a little bit of feedback, it goes a long way. We have them practice, like I mentioned. We do quarterlies, everybody, just to stay on mark. And that's just so, you know, at 3 o'clock in the morning, you can do it just as efficiently as you do at 3 o'clock in the afternoon. Audio information I mentioned is key. If you guys can get voice recordings and actually hear what goes on, that has been a real eye-opener. The manufacturers will tell you that, oh, geez, we're just not there yet. We need, you know, a lot more research and development. Well, that's because they think they know what's best for us. But enough agencies are starting to come around now and ask for it where it should become more commonplace. The practice will help keep your crews focused, especially the new guys. Right? But it's good for everybody. So, and that's an old slide. And, you know, I guess I just have this up there because, you know, if we can do it with 40 agencies now, or 30, 37, 38, and 3,000 plus EMTs, you know, it may take you a while to get there, but you can get there. Whether you're a major metropolitan area, I mean, I know Vancouver's got a huge number of people. Toronto, they've got, geez, thousands. So it can be done. And that's a nice little feel-good slide for you. Something else I'll say is that regardless of where you're at, this actually got brought up in a conversation the other day, you know, it's performance over protocol. It really is. It's paying attention to what you're doing and just doing it right. You know, we do the 30 to 2. Seattle does continuous. Vancouver does continuous. There's not a measurable difference. So basically, it boils down to performance. So, and I think I hit all the notes I came up with. Anybody come up with any other issues or questions at all? Yeah.
Are there any studies or you have any thoughts on mechanical compression devices in Lucas and stuff like that, as far as effectiveness?
You know, there was a company in Seattle that one of the engine companies did a trial, and they actually participate in a lot of kind of ideas like that for their medical director, and so he did choose them specifically, and they didn't see a measurable difference or anything worthwhile to invest in. In the county, we haven't even looked at it. In my thoughts, I would much rather have a handful of you guys than a machine that's vulnerable to breaking down or, you know, a delay in setting up. I mean, I know they'll tell you that it takes a minute or two, what have you. I don't know. Do you have any thoughts on that, either of you guys?
I think this, there's been one large study, and there's another one that just got completed. Mechanical devices are out there, probably where I think they may have a role potentially is in doing transport. CPR in transport is poorly done, and I think it's very hard to do it in the back of a moving vehicle as a human. So I think there potentially you might have better control, but there's no doubt setting the equipment up and reducing interruptions is where you lose it. And in that initial phase, I don't think it adds much. I think actually human CPR performance, based on what we're seeing in Seattle and King County, where they've been doing it for years, I think is really the way to go. I think you can think about it in transport, particularly when you're talking about safety and injuries and other things that can happen. I see a potential value there. It's also potential valuable in, for example, where they're doing reanimation work, where they're actually continuing CPR in arrested folks and actually opening up arteries in the cath lab. This is all research, very high-level research going on in Europe particularly, and also some in Japan that's occurring, but that's potentially where you see it, so you can actually do an intervention but not have to have a person stepping on and off the chest. You can just do mechanical CPR. So there's some fascinating stuff that might change what we do in the future, but for now, at least, I don't think the evidence is strong enough there to, and the cost is the big issue. And like everything else, you drop a machine and it's $15,000 that you then have to figure out how to replace. So I think those have been issues. Dr. Fowler, Dr. Pepe are both medical directors as well. Maybe they have some other comments.
Yeah, that's a great question. We get asked it all the time. Dr. Copas showed that when he first introduced AEDs into the system, his survival went down. The reason it went down is that the focus, and you can correct me, Steve, on this, but I think the focus was, and they learned it quickly, was the fact that they were focusing on the machine and not the patient. The time to get that patient back is in the first 5 or 10 minutes. And so anything that interrupts that is going to be important. The 3 types of people that die, those that they arrest quickly, pop them right back, they wake up and wonder what happened. Then there are those that are dead. They've got end-stage cancer and they're not coming back. But there's that small group that Mo talked about that generally we don't transport cardiac arrest unless you get a pulse back. But occasionally you have a compelling reason. I say this guy in and out of VF that you get shocking. You know that he stands a pretty good chance that if you get into a cath lab, CPR is still going, that we can bring them back. Watch it all the time.
I think it's 4 o'clock. If there's any questions, or I think the 3 of us are happy to stay and answer questions if you'd like. There's a lot we could have talked about. We've had to sort of try to narrow it down into what we thought were pockets. I think that what we're doing, and I think it was commented on earlier today, I think you have to constantly look, because I think that we live in a time where if we're not taking a close look at what we're doing, we got to make sure that what we're doing works, and if it doesn't, we try to find better ways, whether it's in improving patient care, whether it's in firefighter wellness and safety. We got to look at all of those, because by looking, which is essentially QI, QA, but essentially research, we're actually going to hopefully have answers to some of the things that we currently don't know. Ray, you had a comment?
One last point. In Dallas, we decided that we were not going to call it research. Instead, we're going to have a community agreement in how we change our protocols. And then we're going to use the federal money that pays for our staff to be able to bring feedback back to the teams so that they feel more and more empowered as part of the team.
Yeah, one thing is that a lot of things you heard here are summarized very well by Dr. Sacco, whom they referred earlier today, and Dr. Kopis, in a paper that was published in something called Critical Care Medicine in 2009, January 2009, and a supplement there if anybody's interested in looking that up. So it's Critical Care Medicine, January of 2009. And I think it's a special supplement. It's participants here, pages 91 to 101. The other thing I was going to say is that I think what Ray was getting at is we don't call it research. The point is we're trying to get away from these some kind of eclectic things. It's basically quality assurance. It's really advanced, sophisticated quality assurance of all forms, and that sort of thing. And we do it as a group. And I think the most important thing is not we heard today about the communication with medics. The whole thing is getting in from the beginning at the ground level and say how's the best way to execute this, and then constantly get feedback. And you'll have to see in terms of entry of patients sometimes. keeping people involved in one. Last thing is that you will see that a lot of things you're seeing here is based on best available data. And even if it's clinical trials, sometimes clinical trials have their limitation. It may not, what they've often done is not prove that something worked, but they couldn't demonstrate that something worked. Because there may be other variables that screwed it up, you know, so you couldn't see the difference. And do not be surprised that maybe in 3 or 4 years we'll find out that certain, that as opposed to uninterrupted CPR, certain interruptions and compressions may actually be an advancement under certain other conditions. And so that means what they're doing right now is wrong. Based on the best available data, it's the better way of doing it. And maybe we're going to find an even better way to fine tune that in the future, which we'll find out. So the point is, you got to constantly, don't get upset that things are changing. Be excited that things are changing and you're part of it.
These 2 mannequins here are for anybody that wants to try. If you want to come up afterwards and see if you can compress them tonight, you're welcome to try.
So I was going to say that other mannequin, the printout was the record because this one was hooked to the computer. So I know the individual that did CPR never got any feedback on how they were doing. But if you want to look at your printout, you can take a look at that. So thank you very much.
You look like you're